Our demonstration that we're going to do right now is the AROM, or Artificial Rupture of Membranes demonstration. And soon after that, we're just going to do an application of a fetal scalp electrode for fetal monitoring. So our situation would be in this situation that we need to rupture our client Victoria's membranes and then apply a fetal scalp electrode to closely monitor the baby. Before we get started with AROM, so we can probably, we can do that for a view. Some indications that we would artificially rupture somebody's membranes would be for an induction of labor with a favorable cervix, a Bishop score greater than 6, to augment a labor when the progress is lacking. Some risks or complications that we would discuss with our client prior to the procedure would be that cord prolapse, or the cord coming below the baby's head, rupturing vessels in what hopefully we don't know to be a vasoprevia, but we could potentially rupture vessels unknowingly. That anytime you do a vaginal exam or introduce any foreign object to the vagina, it increases your risk of your client having an infection or a chorioamnionitis. It could have the result of producing cord compression with fetal heart rate decelerations. There is always the risk that we may scratch the baby's head with our amni hook. And as always, there's the risk that we may accidentally cause trauma to our client's tissue or cervix. But we can reduce these risks by being gentle and doing a thorough assessment prior to proceeding with the AROM. A couple of contraindications to be aware of would be if we know this person to have a placenta previa. So we've checked where their placenta is and it is not covering the exit. We would not do a vaginal exam if we knew that didn't know where the placenta was, or if we knew there was a known previa. If the presenting part is high, if there's a malpresentation or anything other than a vertex presentation or a head down cephalic presentation, if our client is known to have HIV, hepatitis B or C, or an active genital herpes or HSV outbreak, or any other active infection where the fetus may be affected. A couple of relative contraindications just to be aware of is that you do want to do this with caution. If your client has group E strep positive, syphilis or gonorrhea, or has any kind of infection in their urinary tract. So the first thing you're going to do, obviously, is have a discussion, informed choice discussion with your client about the reason that you're recommending this artificial rupture of membranes. Introduce yourself. If you haven't already done that, ensure that the client has any time to ask questions. Get consent, and you're going to wash your hands. This is a sterile procedure that involves a vaginal exam, so it's important to maintain sterility. I'm going to have an assistant hand me my amni hook once I'm sterile, and I'm going to talk to my client through this entire procedure because it is an invasive procedure. It's important that your client is aware of that. We're going to don our gloves in a sterile fashion. Have my assistant apply some sterile muco to my fingers. Okay, so first we're going to do a vaginal exam. Okay, are you okay if I go ahead, Victoria? Receive consent from our client and let her know. So Victoria, I'm doing a demonstration for the students, so I'm going to be talking about what I'm doing down here, okay? And I'll let you know before I do anything. So I'll touch you here. So you're just going to feel my touch on your leg here. And then are you okay if I go ahead with the procedure? Yeah. Thank you. So you're just going to feel a bit of touch and pressure. If at any time during this procedure you feel too uncomfortable to continue, please just tell me to stop and we'll stop, okay? Okay. So you're just going to feel a bit of touch and pressure here while I identify vagina. Okay, so now I can feel the baby's head. I'm having a good feel around. The cervix is 6 centimeters dilated, and I can feel the membranes bulging, and there doesn't appear to be a cord. I can't feel a cord. I can't feel any vessels that are bounding. I can feel that the vertex or the head, the cephalic presentation, is well engaged. Feel some fontanelles and sutures, and I think we're okay to continue with the AROM. So I have my assistant hand me my amni hook in a sterile fashion. It's important to remember that this is sharp. The end of this is quite sharp, so you can see how sharp it is. It's like a big crochet hook. So when you introduce it into the vagina, you're going to want to make sure that you don't scratch your client's vagina with it. So you turn it to the side and then slide it between your index finger and your middle finger. And now I can feel with my index finger the end of where the amni hook is touching the membrane. I'm using the tip of the amni hook into the membrane and rotating it slightly to tear the membrane in a motion just like this. Do it one more time. And now we can see, remove the amni hook. We can see lots of clear fluid. We're going to note the color of the fluid, the amount of the fluid, if it has any odor, if there's blood in it or meconium. And we're going to take our hand out and monitor the fetal heart. We always want to make sure that the baby is happy after we do perform an AROM. So if you're in a hospital setting, you can apply the EFM. If you're in a home setting, you can listen for a minimum of 10 minutes post-rupture to ensure that the fetus is still, fetal heart rate is normal and that the baby is happy. So in this case, the baby we're experiencing some decelerations. So we're going to move right on to applying a fetal scalp electrode.